Start. Yeah. Good afternoon, everyone. Welcome to the Digital Health North Accelerator, hosted by the 4 academic health science networks in the north of England. Today's webinar will be talking about the Provisio subepidermal moisture scanner made by a business based in Alderley Park, Bruin Biometrics International Europe. And welcome to the webinar. Just a word on housekeeping. So today's webinar is being recorded. If you have dialed in and you find yourself not muted, then it'd be great if you could mute your phone. Throughout, if you want to ask questions or engage in discussion, if you can use the chat box function, should be in the lower right hand corner of your screen. And if you want to try it out, yeah, use the chat box to say hi, let us know you're there. And if you are asking questions, we're going to try and deal with them at the Q&A at the end, actually. But do make sure that you send questions to everybody, not just to individuals. You should be seeing the presentation screen and the chat panel, so hopefully you can. And afterwards, after the webinar this afternoon, we're going to send the recording and slides, contact details, etc., to everybody that was on the call after the session. We'll be going for about 60 minutes, and as I've mentioned, we'll take questions at the end, initially from those that have been sent through via the chat, and then if there's time, we'll invite anybody that's on the line to maybe ask a question verbally. And if we do that, obviously you might be muted, so stay muted until you're speaking. And if you are speaking, asking a question or making a comment, then please identify yourself by your name and organisation. So that's the housekeeping. In terms of today's speakers, you're obviously hearing from me right now. I'm Mike Kenny. I'm the Associate Commercial Director at the Innovation Agency, which is the North West Coast Academic Health Science Network. You're going to hear from Colin Priestley, the Chief Commercial Officer from Bruin Biometrics Europe, and Leslie Lawson, Vice President of Clinical Implementation and UK Sales at Bruin Biometrics International Europe. You'll also hear from two clinicians, so Nikki Orr, Head of Clinical Governance, and Tracy Carver, Quality Lead Nurse, both at NHS Merseycare Foundation Trust. It's worth me saying at this point that you'll hear from Nikki and from Tracy via a video presentation that they've done for us. We had intended to have Nikki and Tracy speaking in person, but we felt like with the current COVID-19 crisis and the call on clinicians and frontline NHS staff, we felt that the video would be the most appropriate way to hear from Nikki and Tracy Carver. So we'll come to that later on. So in terms of what we're going to talk through today during the webinar, I'm just going to tell you a little bit about the Digital North Accelerator programme itself, and also just something about the Academic Health Science Networks for those of us that may not be entirely familiar. Then we're going to hear from Colin and from Leslie about the UK pressure ulcer burden, UK guidance, and we're going to introduce the Provisio subepidermal moisture scanner, the science, the evidence, and the impact. And then we're going to hear from Nikki and from Tracy, striving for perfect care, preventing skin breakdown in a community setting in the UK. So once we've done all that, we'll hear from, we'll hear any questions, do the Q&A, and then I'll summarise and close. So that's the running order. If we get into the Digital North Accelerator, so this is the 4 northern AHSNs, Academic Health Science Network, so Innovation Agency, Yorkshire and Humber, Health Innovation Manchester, and North East and North Cumbria. We're all working together to help innovative digital SMEs within our regions to increase their adoption, so the uptake of their products across the whole of the north of England. And to achieve this, we came up with the Digital North Accelerator programme, and we established this to deliver a range of supporting activity to facilitate adoption and spread across the north of England. And actually, we hope it's not just going to stop with adoption and spread in the north of England. This will also prove to be a channel into the innovation exchange where these products will be supported for national adoption. Interestingly, all 5 companies in the Digital North Accelerator are going to be featured in a Times Future North Life Sciences supplement, which is going to be published in mid-April. So we do hope you look out for that. A word on the academic health science networks. We exist to encourage innovation in healthcare and to stimulate growth in industry and life sciences. And our vision is to improve the health and prosperity of our regions by unlocking the potential of new ideas. Across the country, AHSNs act as a bridge between healthcare providers and commissioners, academia and industry. And by connecting these sectors, we help build a pipeline of solutions for the NHS, from research and product development through to implementation and commercialisation. Locally, we work extensively in partnership with our regional health and care community, and we develop projects, programmes, initiatives that reflect the diversity and meet the needs of our local populations and healthcare challenges. So together we breathe life into innovations that improve care, effectiveness and efficiency in the NHS and social care. And in the year ahead, we'll continue to accelerate the spread and adoption of our innovations with proven impact and value, so that the healthcare system in our regions gains the maximum benefits more quickly. So that's the academic health science networks. So I'd now like to hand over to Colin and Leslie, who'll talk to us about the Provisio subepidermal moisture scanner. Thank you, Colin and Leslie.
Thanks, Mike.
Thanks, Mike. I'm going to start off. We've just got a short slide deck. I'm going to introduce the scanner to you, how it works, what we've done in response to the burden of pressure ulcers, as Mike said, clinically, what we've achieved over the last 5 years, and then hand over to Colin, who will talk about the health economics. So for those that are looking at the scanner for the first time, or they may see that some of the pictures I'm going to show look different to what they have seen in the past, if they have seen it before, because Provisio is our newly launched next generation product, which we launched at the end of February. Everything about the scanner is the same in that it's prevention made real. It is innovative technology. We are reducing pressure ulcer incidence, and through the slide deck, we'll show you how. And we also are achieving quality outcomes. Next slide. So just to put things into context and look at the background of pressure ulcers affect around 180,000 hospitalised patients a year, and even more so probably in the community, although I don't have the stats on that for the UK. The cost to the NHS is greater than £2 billion per year. And in 2020, Sequins are targeting pressure ulcer reduction, particularly in the community and care homes. NICE MIB 182 was issued to us in May 2019. And for those that don't know, this is the MedTech Innovation Briefing, and it's the first part or first stage of the guidance process. So having been issued the MIB, we're now in the second part, which is the guidance, and that's underway. Also, SEM, subepidermal moisture, was referenced in the 2019 International Clinical Practice Guidelines, which were launched in November last year. These guidelines are reviewed only every 5 years, and they're updated, and they have a team of key opinion leaders that review everything. We are in chapter 4, which is the skin and tissue assessment, and it was a significant recognition to have that outlined in those guidelines. Next slide. So what does a SEM scanner do? I think the visual on the left-hand side, what we want to try and show is that biological processes below the skin surface are critical in the development of a pressure ulcer. And what we have is the first wireless handheld device to provide objective, anatomically specific data to support clinical interventions. The objective information on the increased risk of PU supports earlier, and again it's anatomically specific, which we are focusing on the sacrum and the heel, to allow specific interventions that can reverse that damage where possible. It's real-time tissue status. We do monitor and we recommend that patients are scanned daily. From a major study that we did for the launch of our FDA, we were able to show that the 5-day earlier than visual skin assessment was achieved. So we're giving a 5-day earlier than current visual skin assessment. And the scanner acts as an adjunct to the routine clinical assessment. Next slide. So how does it work? The SEM scanner uses biocapacitance to identify specific areas that are increased risk of PU. So tissue biocapacitance rises when the extracellular water content, which we call SEM, increases because it's triggered in the inflammatory response. So we have an integrated electrode sensor which we place onto the skin, and it computes a value which we call a delta from a set of readings. And we take 6 readings on the sacrum and compute that delta, and we take 4 readings on each heel. And on the left-hand side of the screen is just really showing you what the new Previsio looks like. Very different, as I say, if you've seen the previous one. And the sensor you can see at the top, and then on the screen we're giving you some readings that are then interpreted to obviously carry on with the care. Next slide. Next slide. Okay, this is an animation, so I'm going to ask Mike to click on it again, and I'm going to talk you through what actually happens in that inflammatory process. So basically, we know we're going to get capillary widening, we're going to get increased blood flow, which then in turn increases the permeability. And this is where the extracellular fluid comes in, because that fluid is released. And that's what we're looking for when we scan a patient. We're looking for that fluid, if it's raised or not. It then goes on to, in the process of obviously starting to heal, and that sort of process of inflammation. But that is a visual that we often use that helps people understand exactly what we're measuring. Next slide. So the important thing is the evidence that we've gained over the past years, 5 years now, since we launched early 15, and the work that we've done. And we talk about our global real-world evidence. This is evaluations that have been done in everyday practice in a normal ward, in a care setting, or in a facility, whether it be a hospice or a community, and we've done quite a number. So there are, in total at the moment now, we're on over 2,000 patients in 28 sites, 5 different countries, and that's generally the UK, the US, Canada, Europe, Belgium, Spain. 11 different care settings. And I think it's important to say that we're called into care settings that we know that have a PU issue, and they tend to be orthopedic trauma, elderly care, stroke rehab. And you'll see here we talk about 28 sites, and then we go on to talk about acute. Just to point out the non-acute sites that we've worked, and you're going to hear a video from Nikki. It was community, patients at home, looked after by district nurses. And the other area we've done a significant amount of work in is hospice care. But in all of these, there were no changes in the protocol, apart from the addition of the SEM readings. There was no increase in staffing numbers or interventional equipment. So nothing has changed in terms of that. So in the acute side, we've pulled out a few stats really. So we're just under, just 1,952 patients that have come through this. And we talk about the average weighted percentage reduction, quite important because these evaluations have gone on over various timescales, anything from 6 weeks, which is our normal kind of process, to people that have asked to do them longer and rent the product. So we've done it anywhere from 6 weeks to 6 months. And the volume of patients going through those evaluations have actually been quite different because of that timescale, which is why we weight it. But in actual fact, the reduction that we're showing currently is 90.5%. In 73% of those sites, they've experienced zero HAPUs during that PURP, and PURP is Pressure Ulcer Reduction Programme. This is what we term our evaluations. 76% of patients did receive additional preventative interventions, and that was affected by the clinical decision making. And these are some of the questions we ask during that process. So the SEM scanner had an impact on their decision making, which then had them act earlier and put an intervention in place. We review our data on a quarterly basis, and then we keep adding to the number of sites, the number of countries, and that's where we are today. So that's what we call our real world evidence. I think the next slide moves on to our health economics.
So thanks, Leslie, for your overview of the clinical work that we've done. An important part of our work has also been to look at the cost burden to health providers all over the world, actually, to treat pressure ulcers, and then what a difference it makes. What difference it makes when you introduce technology such as the SEM scanner. And just as a point of note, the image that's in the box on the left-hand side of the screen is the M200. That's the original one that Leslie referred to earlier on. But our work has been to demonstrate the difference between what happens to patients when you are able to prevent the skin breaking compared to what the current standard of care limitations are in terms of being able to see what's happening under the skin. And unfortunately, when skin does break and pressure ulcers occur, it becomes a burden to the patient and to the system, and there's a related cost to that as well. So what I want to show you in this slide here is really to capture the image rather than the detail of the numbers, although they're there for good reason to draw our attention. But essentially, this prevention versus treatment slide was prepared on the basis that two patients, we refer to them as George and Jane in our work, both elderly patients, Caucasian, one male, one female, admitted to hospital with a fractured neck of femur. They're admitted, Mike, I wonder if you can just move your cursor over the green area on the graph at the bottom, just right down here. Okay, so this is the point where they're admitted here. Thank you, Mike, just right there. And the SEM scanner is introduced and the patient is scanned to determine if they're at risk of developing a pressure ulcer. Let me, the red line, the red zone shows what happens when a patient is not identified or that early onset of pressure ulcer damage is not identified and the patient goes on to develop a PU. The skin breaks and there is a whole range of interventions and treatment and nurse time that's applied to the management and treatment of that patient. That has a cost to the health service. So there is a cost to treat George in that respect. When Jane is admitted to hospital and the SEM scanner is introduced into the assessment process, we're able to identify earlier that she's at risk of developing a PU and therefore intervene earlier, as Leslie has described in her outline. And the avoidance of the skin breaking and the avoidance of that PU allows Jane to be just discharged from hospital on time as planned. The graph clearly shows that there's a slight increase in cost, of course, to provide that prevention, and we call that out very clearly. But the avoidance of cost for all the treatment-related activities is clearly obvious. I hope you'll see from that slide there. So we may come back to this, but there's a big difference in the cost compared with Jane versus George when you intervene early, because you've been able to detect that damage early. Mike, let's go on to the next slide, and I'll show this in a slightly different representation. So let me show you something here, and this is data that we've taken from a hospital we worked in very recently, where we carried out our PURP, our pressure ulcer reduction program, and we looked at data that existed in a ward that had a 2.8% incidence rate in the prior year, and that was 22 PUs. They had 792 admissions. Now, we know from our research that roughly 41% of patients who are admitted to hospital are at risk of developing a pressure ulcer. Here's where it becomes quite significant, I think. This is a real life example of the costs that are associated with screening and detecting. If we go from the left-hand side of the slide, 100% of patients. This is current standard of care. So everyone is screened and detected right now to determine if they're at risk of developing a pressure ulcer. Some of those patients are obviously identified as being at risk by the current standard of care, and we recognise that. And then there are some actions taken by the nursing staff, all of which have an associated cost. And you can see the things that we are scoping out there on the x-axis of what's involved in these costs. Now, as we move into across to the right-hand side of this slide, and we see the treat and heal section, really we've crossed the line at this point where skin has been kept intact to skin now becoming broken, and people have open wounds and fall very much into the treatment and healing stage. And again, we're showing a list of activities that are commonly taking place in all care settings to try and manage those patients who have developed a pressure ulcer. And we're also showing the cost of this. And this is, I think, a very clear example of why it is costing the health service a significant financial amount of money, and it's a significant financial burden to treat and heal pressure ulcers through the acute setting out into the community setting and all care settings. So if we go to the next slide now, I'll show you how this changes when we introduce the SEM scanner. And again, this is a live example of the same hospital that I referenced previously. We still have the same screen and detect procedures taking place when the patient's admitted. But now we're introducing the SEM scanner right here in the second column on the left-hand side of the graph. Patients are being identified as being at risk earlier because of the introduction of this technology, and the interventions are being applied earlier. And as Leslie confirmed earlier on, this is no additional equipment to what the hospitals or the care staff already have. So we're clearly calling out here that there's still a cost associated with the prevention phase of our work with patients. Our opportunity is to reverse that damage, and that's what's happening here. In other words, because of early detection using the technology, the SEM scanner, we're able to help reduce the number of hospital-acquired or community-acquired pressure ulcers that happen. We're able, therefore, to keep more skin intact. We do that by keeping more skin intact. And when we keep the skin intact, we're avoiding the significant cost associated with the treatment and healing phase. Now, in this hospital, they had a 100% pressure ulcer reduction compared to the previous year. So the 22 PU previous year as reported. Reduction. You can see on the top left-hand side of that slide there that the total spend per annum is almost £84,000. The saving per annum, 50. All of those instances where patients have gone on to have a pressure ulcer. And then when you introduce the technology, i.e. the SEM scanner, there's a net cost of almost that's in one ward that we carried out, one ward in one hospital we carried out this pressure ulcer reduction programme. So a significant shift there. Green box on the right-hand side indicating can be achieved from a financial perspective. The outcomes of clinical outcomes improved and financial and economic really coming together. Present this is customers are very happy that their bed utilisation are better and see other patients having that bed available to them for a year. Next slide, if you can go into it now. Exactly. Only this time we've referenced the 90% reduction in PUs, which relate to real-world evidence reference that Leslie gave us earlier on. And it's driven by 90% net savings in the top left-hand side of the difference between the previous slide and this one. So we three slides that I've shared. Independently commissioning Deloitte. We asked Deloitte to do all the financial analysis independently of our business, and they've used all the hospital coding systems and nice CG179 references to the costs associated with treating and healing pressure ulcers. And we've used all these costs that are in the system and added that to some information provided to Deloitte directed by customers to build this picture of the potential cost saving. So to suggest that we're very open to them to the point that we can present this data to you. So these slides have been helpful in terms of trying to show not only how to achieve some significant clinical outcomes, but how these translate to a number of other outcomes. Next slide, Mike.
Thanks, Colin. So as I mentioned earlier, we're now going to hear from some clinicians, Nikki and Tracy, who can tell us about their experience in preventing skin breakdown in a community setting in the UK from their work across Merseyside in the NHS Merseycare Foundation Trust.
My name is Nikki Orr. I'm Head of Clinical Governance for Merseycare Community Division, and I'm going to talk you through today the pilot implementation of the SEM scanners and how we're moving that to business as usual across the Community Division and the wider Trust. So you can see from the first slide, and I want to put into context the size of Merseycare. So we're part of 4 divisions within Merseycare. We've got our specialist, secure and LD. And we've also got community division and local mental health division. The pilot's concentrated on the community division, and we will come on further in the presentation about how we're looking at implementation that in mental health. Merseycare is a foundation trust, and we currently have over 8,000 staff, and we continue to grow as a trust. We serve a population of 11 million, and we have 780 inpatient beds currently within the trust. Our Community District Nursing Service provides a service to patients registered with a GP, and this service delivers and provides nursing care within the community to patients within their own home, and that could be specific to nursing homes, care homes, or in their own home. Just to put into context the size of our local population, it's currently, we're serving a population of over 740,000 patients. So I just want to put some context into the background of our position over 2019 and 20. So we had 445 patients on our caseload with pressure ulcers during that period, of which 211 patients had a pressure ulcer on admission. 200 developed a pressure ulcer on the Merseycare caseload, and 34 patients actually deteriorated in their pressure ulcers within the Merseycare caseload. Just to give some background as to why we implemented and looked at the SEM scanners, Merseycare has a pressure ulcer reduction programme, and that's been in place for the past probably around 3 years, and that was very much a collective approach between ourselves and our CCGs to aim, and our aim was really to reduce pressure ulcers within the community. So this project gave us a real opportunity to demonstrate evidence around prevention and the reduction of pressure ulcer development by using the SEM scanners. We were introduced to the SEM scanners by NHSI, and we immediately saw it as a potential to support our pressure ulcer reduction programme. How we delivered the pilot, we worked really closely with BBI on mapping out where the pilot would be and how we deliver that. We were one of the first community trusts in the UK to take the pilot of SEM scanners into the community. It's been well evidenced and evaluated in acute trusts, but there was limited evidence within community. And we wanted to really focus on how we could make the pilot as meaningful as possible. We identified 2 district nurse bases, one in Sefton and one in South Liverpool, and we agreed a 12-week pilot. And we actually extended the pilot because we felt it was the first one in the community, and we absolutely wanted to get the evidence to support that. We focused on our palliative care patients, and the reason we did that was because palliative care accounts for approximately 40 to 55% of the district nursing caseload. We know that our patients can remain on our caseloads for varying periods of time. 50% of our patients could be on the caseload for over 4 years, and the other 50% are on the caseload for approximately 4 to 8 months. And we used our data intelligence from the previous 5 years to look at this. We had regular meetings between Merseycare and BBI throughout the pilot. So in preparation for the pilot, we looked at 12 months data of our palliative patients with DN caseload for each team. Because the palliative patients were on the gold standards framework, we excluded red patients, which were in the last hours to days of their life, and we focused on the green to amber patients. We had 12 months data from our incident reporting system, and we looked at the pressure ulcers from each team, and there's 24 district nurses teams across Liverpool. We reviewed incident reporting systems data to identify the pressure ulcers, which were palliative patients within those 2 specific district nursing teams. And we reviewed that data with the purpose of identifying how many pressure ulcers and at what stage they were. So were they on the sacrum, the heels, and their categories, were they a category 2, 3, 4, or a DTI. So our data collection stage was, we identified we'd look at September 2017 and 2018. So from a Sefton perspective, we identified that there was 141 palliative patients on the caseload, and 9 of these developed a pressure ulcer on the heel or the sacrum, which gave us a 13% incidence rate. In South Liverpool, we had 89 palliative patients on the caseload, and 18 of these developed a pressure ulcer on the heel or sacrum, which gave us a 20% incidence rate. So how did we implement the SEM scanning pilot? We were really apprehensive about the impact on clinical capacity, and our DNs work to maximum capacity every single day, and we didn't want this to be seen as a task and in addition to their current workload. So we very much sold this as part of the holistic assessment, and we're really proud in Merseycare that we've moved away from task focused care. So we added this in as an intervention in the prevention of pressure ulcers. We used healthcare assistants as opposed to trained staff to undertake the SEM scanning out in the patients' homes, because it's very much the interpretation of that data back at base with the clinical expertise that's critical. We also found that by doing that, the healthcare assistants really grasped this innovation and ran with it, and they were key to the critical success of this. They also felt that it maximised their potential in the team, which times healthcare assistants don't feel valued as our trained staff. The selection of patients on the caseload was selected from the data that we've previously discussed. And we agreed that patients would be scanned 4 to 5 days per week over the 12 weeks. Ideally, we wanted them to be scanned 5 days, but we always knew that capacity, demand, and also the patient's condition could dictate that that might have to go to 4 days. We took a decision to discontinue the scanning over the Christmas period, and that was based on, we thought that families wouldn't want us there over that time. And actually what we found was some of the patients really engaged with this themselves and actually asked for the scanning to be continued. We used an algorithm which we used for our decision making, and that was also to support staff in the implementation. So the implementation of the 5 palliative patients from each locality on the gold standard framework, so that was 5 from Sefton and 5 from Liverpool. They had to have a Waterloo of 10+, and there was daily readings over 5 to 7 days. For the 12 weeks, there was 6 readings from the sacrum and 4 readings from the heel. And you can see from the algorithm, if they had a normal reading of less than 0.6, they were deemed to have no risk, and we would continue with our normal plan of care. If they had a normal reading of greater than 0.6, they were deemed to be at risk. There was an escalation process, and that would be delivered in conjunction with our qualified clinical staff. We'd look at our holistic assessment, the equipment the patient was receiving, our repositioning regime, and our shared decision making. Shared decision making for us is about very much keeping the patient at the heart of the decision making. If the patient has capacity and they choose to act against our clinical advice, that is our shared decision making. We want the patient to be as engaged and part of their clinical care as much as possible. Our pilot findings. From the 17 patients that were scanned during the pilot, 697 readings were taken from 2,788 data points, and they were all captured for analysis. So 59% had an SEM delta reading, and of those, 15% had visual discoloration. 41% had SEM delta with no visual discoloration. And the types of interventions we used from that was that 71% we reviewed their turning regimes, 71% we actually reviewed the specialist mattresses, 86% we looked at heel support and was that appropriate and could we change that, and 60% we actually looked at their dressings or their barrier creams. So 82% of our staff indicated that the SEM scanner impacted on their clinical decision on that day, and 94% indicated that additional interventions were taken. We also found that during the trial, 2 patients developed a category 2 pressure ulcer, and they were both in the South Liverpool area. Both patients had raised delta readings leading up to the development, but they had no visible evidence, for example, redness. And that's a really critical point because historically and culturally, we would look for visual signs of deterioration, but the SEM scanner actually identified that those delta readings had raised, but there was no visible evidence, so they were the prompt for us to do something different. We raised the delta reading, remained following the pressure ulcer healing. So we looked at these patients after the pressure ulcer developed, throughout their wound care, but actually once they'd healed, what was the delta readings post-healing, and they continued to remain raised. They were both classed as unavoidable on further assessment, as what we identified was that the patients also chose to decline our interventions. So we'd use shared decision making. We'd fully informed the patients that their delta readings were raised. We wanted to change their equipment regime, their turning regime. We wanted to look at their wound care and their barrier creams. These patients declined to engage in that. They didn't want any additional equipment. So we have to recognise that was patient's choice, and that actually we couldn't avoid those category 2s developing. So in conclusion, we completed this pilot during winter pressures. So within Merseycare and within the NHS system in a whole, winter is an extremely challenging time. So we're really confident in the pilot because it was developed and delivered during our peak capacity times. We had really strict criteria, and staff identified patients out of criteria that would benefit from the SEM scanning. And I was really, really confident in the criteria we developed. We worked so hard on developing that with BBI. We wanted to make sure that the pilot was robust and gave us as much evidence as possible. And I think we need to recognise that at the time of the pilot, we were one trust, that we had 2 incident reporting systems. And that was really challenging for us. We were trying to capture data for over 12 months from 2 different incident reporting systems, but we absolutely invested in that time to make sure that the pilot had as robust data as possible for us to start measuring against. So in conclusion, our analysis revealed that there was a 26.9% reduction in pressure ulcers in palliative patients during the SEM pilot. And you can see from the chart that the pre-pilot we had 16.1%, and during the pilot that reduced to 11.8%. And as a result of that, and that real clear demonstrable reduction, the Trust took the decision that they would procure 24 SEM scanners for rollout in the community division. And then our plans now are to take that further into the Trust through both the community and our mental health inpatient beds.
Hello, my name is Tracy Carver and I'm Quality Lead Nurse in the Community Division of Mercy Care. I'm going to cover the next steps immediately following the pilot, and also how we're going to make sure that our SEM scanners are business as usual within Mercy Care. So immediate next steps, we did the pilot analysis, where we presented the findings to the Community Division and to the Trust executive team, and these were really welcomed. And the impact of the pilot enabled a direct correlation to our wider pressure ulcer reduction programme. The Trust exec team thus agreed to procure SEM scanners for every district nursing team, as well as our inpatient ward, Ward 35, which is we class as intermediate care. The mobilisation plan developed in conjunction with the operational leads and frontline staff, and we reviewed the criteria for scanning in line with the pilot findings, and we devised the clinical decision matrix, which is on the next slide. Okay, so this is our clinical decision matrix, which is constantly being refined and reviewed in line with any new findings that we're getting. And just as a basic guide, on the left-hand side is what we do if patients have a delta reading of less than 0.6. On the right-hand side is the actions if it's greater than 0.6. However, clinical judgment should always be utilised, and review the scanning frequency of any clinical concerns or any deterioration within the patient's condition. Okay, so now we're going on to our mobilisation plan, and this is whole scale across our community division. So our initial phase commenced in July 2019, and we've continued with the PDSA approach that we started, where we have proper clinical evaluation monitoring for each team rollout. We developed guidance, and a SOP was developed to support staff application. A patient information leaflet was developed, and training and education was rolled out, and this was with the help of BBI as well as the Care Foundation Trust Pressure Ulcer Training Programme. We identified key trainers, and we implemented a train-the-trainer approach. We made sure that there was a communication plan in place, which again is constantly being refined, and a competency framework has been developed. The SEM scanners are to be implemented across 24 teams. Our current position we have implemented within 21 teams, and each team is finding them such a great benefit within the team. Challenges that we have is as the Trust move forward for patient electronic records, so now all our district nurses are paperless. So we've developed an EMAS template, and we're reviewing and amending the rollout to meet capacity and demand. So what did we learn and what did we do? And this is with our first rollout. Okay, so initially we reviewed the scanning because we were scanning patients over 5 days, and we could see now with the evidence that we got, we could reduce that to 3 days. We had a review of the criteria, we got feedback from staff, and we provided support and tried to resolve any issues, challenges that had arisen. And also, as with any PDSA cycle, we reviewed our PDSA. So our next steps, we're going to link the competencies to the staff training records on the electronic staff records, which is ESR. Continue with our PDSA approach, where we continue to review all data. We've got a performance dashboard currently being developed, and this is not going to just look at quantitative data, we're going to really consider the qualitative aspects to our patients. We continue to raise the profile of SEM scanners across the community division and trust, with the benefits and links to the wider pressure ulcer programme. And as we've said previously, we're rolling out to wider mental health wards and other areas within the trust. So we made sure, in essence, there's been a full review and update. And this is a constant review because it's a dynamic process and we're finding out more information, more data's coming through all the time. So we've reviewed our clinical decision matrix. I'm now going to show you our SEM scanner flowchart, which again, because it's under review, this is version 3. And we've also reviewed our SOP. So that now concludes our presentation, but we'll be welcome for any questions, queries, or any comments at Merseycare. Thank you for listening.
Wonderful. I hope that you found that video of Nikki and Tracy and how their teams have adapted and found great improvement in the holistic care of their patients. Really, really interesting. And our thanks and gratitude go to Nikki and Tracy and all of the teams that have worked on that programme so far. So thank you. We're now at the point of the webinar where we can take some questions and answers. So we've been looking at the chat and we have got a couple of questions from some of the delegates. So Colin and Leslie, can I just check you're with us?
Yeah, I'm still here.
Brilliant. Okay. So the first question is from Paul Humber. And the question is, could this technique be used for prevention of other wounds? So, for example, diabetic foot or venous leg ulcers?
Shall I take that, Colin?
Go ahead, Leslie.
Yeah, it's a good question in that since we've launched the product, we get asked all the time about can we use it here, can we use it there? And we have commissioned and we've started to do some work in diabetic foot. It's an obvious one, I think, and it's one that's been questioned to us. I think, as you imagine, Paul, when you launch a new product, the focus is to prove something time and time again, which is why we focus on sacrum and heels, because the pressure ulcer issue that we're trying to resolve, probably 85% of them are in the sacrum and heel. We're aware that we have others, medical device, etc. But in terms of diabetic foot, that's certainly one that's started, and it's been done through the Royal College of Surgeons in Ireland with a lady called Zena Moore, professor, who's very sort of high in the pressure ulcer prevention sort of programs, really.
Thank you. Thank you very much.
I just want one quick comment to that. Thanks, Leslie. The other opportunity we have, Paul, and everyone else, for investigating these other clinical areas is the design of the Provisio scanner compared to the design of the original SEM 200 scanner. It's one of the advantages we've gained is that we can now, because of the reduced size of the sensor head, have more access to areas of the body that maybe have device-related pressure ulcers. And as Leslie said, we're already investigating areas like diabetic feet. So we've got some real focus on how we can add value to where the scanner can be used.
Okay, great. Thank you both, and thank you, Paul. A question here from Andrew Cooper. Are the sites? I think you maybe already started to answer this, but are the sites just linked to heel and sacrum because they're the sites that research has focused on to date? Is there any reason why it couldn't be used on any bony prominence? Yeah, I don't know if there's any more to say, Colin and Leslie.
I think
Only one comment I would make there is that if we have any contraindications, the main one is broken skin. Our job is to help nursing staff and carers keep the patient's skin intact. If the skin is broken, it's too late to use the technology. So that's the obvious important contraindication for use. Really, beyond that, we haven't done any work in paediatrics, but we intend to start that at some point later this year as well. And that would have been the only other contraindication that was evident from the scanner. So it can really be used anywhere. It's a very low risk device. There's nothing that the scanner does that can bring the patient any harm. And really, it's about optimizing where most of the PUs are found right now, sacrum and heels, and then advancing that as much as we possibly can. But there really are no limitations as to where we can scan.
Yeah, I think, Colin, I would agree that we know through the work we've done over the last 5 years, the potential, is significant to move into to look at other areas, and now that's been helped by the change of the design of the scanner that will actually assist us to look at other areas as well.
Okay, I've asked on the chat if there are any more questions, and I'm not hearing that there are, or seeing any comments that there are, and I'm just thinking about the time as well, and so I think I'd like to move on from the Q&A at this point. If there are any questions that you didn't get a chance to ask, then by all means, send them direct to Colin and Leslie. I'll share the contact details shortly, or myself, and we'll make sure they get answered. But thank you very much for that. So we're going to wrap up now. We've just got a couple of slides to wrap this webinar up. So as I said, we've got contact details, so we'll share the slides and the recording. And if you want to get in touch with any of us, hang on, we have got a question. So this is from Andrew again. Was thinking in relation to people with neurological conditions that may have contracted hyperextended limbs and therefore suffer pressure damage elsewhere. So your response is helpful. Okay, so a follow-up comment. So my apologies. Yeah, thanks for that, Andrew. So yeah, here are our contact details. We'll share those. And this is the final slide. So this actually concludes the Digital Health Accelerator series of webinars. And thanks to everybody that's attended today. You can see more about the Provisio SEM scanner and all of the Digital North Accelerator products in a forthcoming Times supplement. So we're expecting that to be published in mid-April. Keep your eye out for that. And if you are interested in knowing more about the Provisio SEM scanner, please, we have a great working relationship with Colin and Leslie and all of the team at Bruin Biometrics. Please contact them direct. Or actually, if you want to go through your local AHSNs, that's also fine as well. We don't mind. We'll pass the messages on, and it'd be good to hear, how that works. So from me, Mike Kenny, from the Innovation Agency, on behalf of Colin, Leslie, Nikki, and Tracy, I'd just like to say thank you for your attendance today, and hopefully see you all again soon.
Thank you, Mike, for organising, and thanks to everyone for coming on. It's been a pleasure meeting you like this, and we hope to be able to speak to you soon.